Hi, I'm Scott Aronson with Russell Phillips and Associates, and I'm here with Deputy Chief Mike Ciccarelli from the Hartford Fire Department. We're here at Hartford Hospital today as we're going to go through how to deal with fires on surgical patients and deal with evacuation from the operating rooms. And I personally have been involved in the review of about 40 surgical fires on or in patients, so we're going to bring some of those experiences to you to help you understand how to address situations like this.
I'm Mike Ciccarelli. I'm the Deputy Chief at the Hartford Fire Department, and I've had the good fortune of having almost a 26-year working relationship with Hartford Hospital, life safety and risk management folks. We've had continued success here as a result of a relationship that we've had. I think one of the earmarks of a good program is to establish rapport and a working relationship with any hospital facility before an incident occurs.
In this section, we're going to cover a little bit about how to suppress a fire on the patient. We have really 4 types of fires that can occur on the patient. One that will take place in the airway of the patient, so in the ET tube. Another fire that could happen in the oral cavity, so let's say during a tonsillectomy. Have a fire that could happen on the skin, hair, or surgical site of the patient. And then finally the drape fires. So we've got really 4 that we have to address. The airway fire in the ET tube is something that the nurse has not as much involvement in. It's really the anesthesia provider who's going to direct that, because that means we've got flame inside the ET tube. Critical actions that happen there: shut off the medical gases, disconnect that breathing circuit, and then pull out the tube, extubate the patient. Now the important part there is once you disconnect the breathing circuit, that fire actually goes out, but that tube will be melting and will actually could fuse to the throat if you did not remove it. The second type of fire we have in the oral cavity, the quick actions of the staff, again, are the same. Anesthesia, shut off those medical gases. Usually the scrub person or the nurse or the surgeon even could be the one that pulls a bulb syringe over and squirts that right into the mouth of the patient and is going to put out the fire immediately, and then you go through protocols to treat the patient from there. The next fires get a little more complicated because we have so many other things that are involved with the patient. So skin, surgical site, or hair of the patient. If the ignition takes place, fastest actions: get those medical gases shut off at the anesthesia machine, and then take that bowl of saline that's on your back table and just dump it right onto the area where the fire is. You may have to slightly pull back some drapes in order to do that, but make sure that the fire is out. And then once that's done, once you've dumped the saline on it, pull back the drapes from the patient to look for any additional residual burning that could be going on underneath there. The last thing we want to see is that some alcohol-based prep drip down behind the patient and there's additional flame that's taken place. The most challenging is the actual drape fire. In the actual drape fire, there's 3 methods to put it out. Method number 1 is that we can actually pull the drapes to the ground. That's a good way. You can get the fire right off the patient. I'd much rather have it on the ground than on the patient, but it's not always the easiest one. It's sometimes more challenging because of all the things we have where we've got clamps, we've got lines running through it, so it's not the easiest thing to pull off. Plus, if you ever do pull the drapes off and take drapes that are on fire and throw them down on your floor on the way out, you could actually be obstructing yourself slightly from getting out of the room. So be a little cautious about that. The next way to deal with it is, you all know where your saline is. Grab the saline right off the back table and dump it on there. You have to hit it right on the money, because drapes, when they're on fire, are fluid resistant. So you have to hit the drapes right on the spot where the fire is, and then still pull back the drapes from that area and look for additional burning that's going on. And the final way is to smother it. Now I want to do some clarification here on smothering. Smothering does not mean patting. Patting is not the right way to do that. What you're doing is you're fanning a flame, you're actually feeding at that time, and you're pushing the flame out in multiple different directions. I'm going to show you just so you can get a visual on how that smothering piece takes place. The first part, when you see what patting does to it, just watch what will happen as we pat down. I'm patting, it pushes the flame in different directions, but it doesn't totally go out on its own right there. So patting really moves the flame out in multiple different directions. If we're actually going to suppress a fire on the patient, one of my best tools for smothering is something as simple as a surgical towel. I need to protect the airway of the patient. So if the head of the patient is right over here, and then my fire is right here on the chest, I need to do everything I can to protect that airway of the patient. So my job is I need to grab this surgical towel, spread it out. I'm going to drop my arm right in between where the airway is of the patient and the fire, closer to the fire, because it could be down on the legging too. So we want to get up close to the fire. Always position yourself between the airway side. And then I'm just going to take this, I'm going to drop this right over the fire. And at that time, my role is to sweep, not pat, that would push it. I want to sweep the fire out and then I'm going to pull back and let the heat out. Notice that when I do these things, I don't put my face right in that flame. That is the last place I want to be in case it reignites. So I'm always positioned behind here because protecting yourself is just as important, if not more, than protecting the patient at that time. Okay, so I'm going to drop down, call out my code word, make sure I yell that out, throw this over, and then I'm going to sweep the fire and then pull back and let the heat out. And at this time, I can see that the flame is out without getting my face into there. And I'm going to pull all the rest of the drapes off to look for any additional burning that's taking place under the drapes. Now, Chief's going to show you a little bit about how to put out a fire on a human body, because you have a few more contours to the human body.
Again, arm tight across the patient, down, sweep, lift the vent, release the heat, check for extension.
Fires on electrical equipment are challenging in the operating room. You actually have a significant amount of electrical equipment that's all around here, from the anesthesia machines to the C-arms that come in to our BOVIs, our electric cautery units, electrosurgical units that are here. And the only important facts to remember is if you have a fire with electrical equipment, priority number one is you and the patient. So that if you deem that you cannot address that fire in any way, you are then forced to get yourselves out of the room and out of harm's way. With regards to a fire here, most electrical equipment, for example, here's an electric cautery unit. These are reinforced plugs that are on here as well, so that if there was a fire with this electric cautery unit, you can pull the plug from the wall and you would eliminate the energized field that's right here. The important part to remember with that is you never go to pull a plug if A, you feel like you're in danger in doing so, so there's flames around here and you don't feel you can get to it, or B, if the fire actually is taking place or sparks or smoking are coming from the actual plug itself. Other than that, you can safely pull a plug. So just think about it. If you feel you're in danger, don't do it. Get yourselves away from this area. Don't deal with trying to address a fire condition at that time. You also have extinguishers that can be used on this, and the extinguishers that are rated to handle this are the ones that have the C on them. It's got to have a C involved with it, C for current, for electrical current. So realize that type of extinguisher must be used. In the OR, you have to have a clean agent type extinguisher, and you can talk to your fire department, fire marshals about that. And in a little while, I'll have Chief Ciccarelli is going to talk about that as well. Chief, I know we were talking about a standpoint of a fire in the room on the patient, and we saw how that could be handled pretty quickly on the patient. But what type of fire or smoke conditions do you think could force you from the room to actually have to evacuate?
As you said, the small fires we can protect in place, fight the fire on the patient, usually put it out. It's those fires or smoke conditions that begin to escalate that actually worsen. Smoke or fire coming from the ceiling area, they're coming down upon us, from the floor area, from the walls. When a situation like that occurs, we should automatically start thinking about evacuation. Sound the alarm, let them know what's going on here, and then we'll dedicate resources to assist you with that.
Great. Even on those small fires, if they don't sound that alarm, are you coming after them?
Correct. I mean, if we have a small fire that's not thoroughly investigated, as you said, as was shown, is you could have a fire on a patient, put it out, think you put it out, and actually it's burning behind them on the prep that went down behind the patient.
Yeah, that's an interesting process how it all comes together. I know if we have to evacuate a room, there's some key actions that staff have to take in this room. You've got your minimum team of 4 in most situations. We've got our circulator, anesthesia, scrub person, and the surgeon in there. So what we need to make sure is the surgeon and the scrub person own the actual surgical site. They need to package that surgical site for transport to protect it as much as possible. Anesthesia is going to own the medical gases and controlling the airway of the patient so they can get any drugs necessary to be able to transport that patient in an emergency, bring that table to the unlocked position, and get prepared to evacuate. And finally, the nurse in here, the circulating nurse, is going to run the walls of the OR. So runs the walls of this room anyways. They're going to be the ones who are communicating out of the room to ensure that alarm gets pulled if they weren't able to pull it themselves. And then they'll be clearing the path to the door, because we know if smoke's building up in this room, and they haven't cleared that path to the door, then you may not be able to find your door by the end of it all there.
That's correct. That's why it's important to have a working relationship with your local fire department. So bring the fire department in to educate them how an OR works or how a hospital works, so they understand the concepts of what takes place when an actual event is taking place on an OR wing. Most importantly, that decision is always made, it's probably made prior to the fire department arriving there. Yeah. But it's also important to us to know that that is going to take place or is taking place, because we will dedicate resources to that wing or OR to facilitate that. That's why it's so important to have, whether it's a circulating nurse or charge nurse, somebody in charge has to meet with fire department personnel so that we can partner and make a decision together.
I'm right by your side.
Correct.
They know the clinical aspects, you know the building and fire protection aspects of it. Yeah, I know that when we've looked at a lot of evacuation, it's so critical that that department that's here, the OR, makes decisions ahead of time in being able to say, where would we evacuate our patients to? First goal is always horizontal. We're never going vertical unless we are absolutely forced to. And so horizontal movement, we want to go to an area that's in a safe zone, which means in another smoke compartment.
Correct.
So we have to get them to a safe
Correct.
zone.
And also part of that plan is, where are they going to? We have made the decision to evacuate. Where are they going to go to? So from point A to point B, where is point B? That should be part of our evacuation plan. If it's not, we should actually make sure that, we would want to make that decision if the hospital is not going to make that decision. And usually the hospital will prefer to make their own decisions.
Yeah, they would. They like to make them ahead of time, because you know that the fire service knows, again, the fire aspects, and they know the clinical aspects.
Correct. And horizontal evacuation is the most favorable method for the fire department. We can put them in a fire safe area, as you've learned before, with rated construction and doors, that maybe simply just moving them to another room would be sufficient, versus having to move them to another compartment within the hospital area.
I know we've always looked at it, if the fire's out in a room, but they were forced to evacuate that room because of smoke conditions, then the charge nurse in that area may make a decision to move them to another room, and then you guys will come in and address, just to verify fire's out and everything else.
Correct.
And so there's a lot of key actions that may happen in those first 0 to 5 minutes before fire department's on the floor.
Correct. And if it's a smoke condition that's in another part of the hospital that's invading that wing, that OR wing, the fire department may decide to keep everybody inside the OR rooms themselves versus moving them, because it's much safer in a smoke barrier versus putting them out in a common hallway where we have smoke encroachment.
Yeah, I know the philosophy is, if I'm in clean air right here,
I
don't want to move into smoky air. I guess as we summarize our facts, is it's got to be fire or smoke conditions have to force them from a room to want to leave at the middle of a surgical procedure. And then after that, it's really decisions by the charge nurse and then with the fire department about evacuation of other rooms.
Correct, because it's important to us to have that information. You certainly don't want the fire department coming in and shutting down medical gases to areas that are being utilized, as well as shutting down breakers into rooms that are using energized equipment.
I think our final point that you and I both always have a challenge on is that if we had a fire in a room and that patient was involved in that fire and it was significant in a way that the patient is fully engulfed in flames, or in a way that you just, due to smoke or fire conditions, can't get to someone, you in a worst case scenario, you may actually have to leave, close the door and leave a patient in a room. And we hope that never see that happen, but we'd rather save everybody else on the unit at that time. You save the most people you can
Correct.
save.
Self-preservation. By that time, the automatic sprinkler system will be activated, but also leave the room, close the door behind you.
The National Fire Protection Association, the NFPA, came out with a tentative interim amendment. It's a tongue twister right there, TIA, that was basically stating that alcohol-based prep solutions need some very specialized treatment in the operating room. Probably the most important part there, and this is where a lot of the fires have happened, is that the surgical teams need to know that if this fire actually takes place now based on an alcohol-based prep solution, the whole surgical team is liable, because there's a formal code that's come out there that stated that they need to adhere to this. And it was interesting when NFPA came out, it was due to a fire where there was a fatality, supposedly addressing and associated with alcohol-based prep. And so the plan today now says that any alcohol-based preps must absolutely be 100% dry before you start draping, squaring off with towels and everything else, because you have alcohol, you add a heat source to it afterwards. If that hasn't dried, or if it's soaked into any of the towels, you've got a major fire hazard right there. So it was just interesting to see it all come out and play out, but facilities really need to make sure they institute that final timeout that says, if you make sure the prep solutions are dry before draping the patient. tough one, challenging one out there. A lot of facilities we're seeing are having the surgeons now go out and do their final scrub before they come back into the room, so the prep has time to dry in between that as well. The fire extinguishers in the operating rooms is a huge controversial topic out there. Fire department, fire marshals, authorities having jurisdiction, everybody has their own opinion of it. All that we know when we go in is we need to make sure it's a clean agent extinguisher, and we need to make sure it won't harm the patient. So those are our first two things that we really come down to. Chief, what would a ABC dry chemical extinguisher do if you discharge it in this room?
Pretty much make an entire mess of this whole area, because we're going to discharge agent and powder throughout and pretty much contaminate not only the patient, if there is one here, but all the equipment, everything associated with this room. That's why part of extinguisher selection is referring back to the process of what takes place inside your room. It's not only education for staff, but education for fire service personnel. Bring them in. That's why it's important to establish that relationship with your fire marshal or fire chief or fire department. Bring them in. Here's what we're doing. What is your recommendation? And it's also an opportunity to educate them. What's going on? Here's what we need this for. This is why we think this extinguisher is better than this one. And again, training is another issue. We may have an opportunity to select extinguishers, have discussions with the fire department as far as what works well, but if we don't train with them is the biggest piece. So we actually have to have surgical staff train with them how to put out a fire using a fire extinguisher.
That's great. That's really good the way you interact well with the hospital side. Today we covered surgical fires and what to do if a fire actually occurs. As you saw, in 1 to 2 seconds, it's really all the time you have to think in being able to manage a fire. And we really want to thank Hartford Hospital for letting us work within their ORs today, and this is a great opportunity to be in their hospital, and to thank Chief Ciccarelli for all of your support, and really shows a lot of the work that you've done with the healthcare facilities in your area, and this will help everyone to understand that better.
Well, I think it's important for healthcare professionals to understand that the time to establish relationships with the fire department and establish rapport is not when an incident occurs, it's prior to that. Get the fire department and emergency service people in your healthcare facilities to understand the concepts of the services that you deliver within your facility.